So, right off the top, want to thank the panelists for sticking around to the end. There were a number of questions relating to diet, prevention, and post-diagnosis. Can anyone on the panel speak to?
Dr. Pfeiffer will.
Happy to. It's a very common question I get as a provider. I'm sure Robin agrees. The short answer is there's so many studies that looked at different phytonutrients and so many different things that have been studied. Most notably, the SELECT study, people were thinking about vitamin E, selenium-rich foods, things of this sort. For many, many, many years, people were pounding down vitamin E and selenium and vitamin D and lycopene and saw palmetto and all these things. And lo and behold, the SELECT study showed absolutely no benefit whatsoever. That's just one study. What I say to patients when they ask me, what can I do with my diet? I say almost uniformly, what is good for the heart is good for the prostate. And that's what the evidence shows, including aspirin, for instance. The strongest evidence to suggest prevention of prostate cancer is with aspirin, statins, and to a lesser degree metformin, but the data is not as strong. You know, those are drugs. But when it comes to food, having a primarily plant-based diet with low and saturated fats, with a focus on weight maintenance, is found to be the strongest evidence of prevention of prostate cancer. And that's especially also prevalent in some studies that have looked at Asian Americans who have Asian Americans who have come from Japan, who have moved to the U.S., for instance, that the change in diet can be associated with an increased risk in prostate cancer from a more plant-based, I would say healthier diet to a traditional American diet, which is not as healthy. So it's very important to focus on the overall wellness when it comes to prostate cancer prevention and diet.
So Dr. Matthew, this question, I believe it's for you regarding the peer navigation. Sexual health outcomes are particularly important for men who have sex with men. With regards to Black men, this is even more important. How do you address this in your work?
That's a very good question, and in fact, a timely one. There is very little information in general about sexual health in gay men, bisexual men, and men who have sex with men, let alone Black men that have sex with men. And so that is certainly an existent gap in care. I'm actually speaking at the Sexual Medicine Society of North America's conference on November 17th. And a group of us come together to do what's called a master class on taking a look at assessment and treatment for sexual health in general. And we've collected a multidisciplinary group. And my 15-minute section is actually specific to gay men and bisexual men and men who have sex with men in terms of being sensitive to the unique issues that those populations experience and how to have their interactions with the healthcare system more user-friendly, more open to allow for a specific discussion about the experience. To the degree to which we can get down to Black men having sex with Black men, we're a long way from there. And my bridging of that from my experience is that what we know about Black men, the unique experiences of Black men with prostate cancer who are recovering from treatment. I can take some experiences from that, and also my work with gay men and bisexual men and men who have sex with men, and try to combine those. But it is definitely an area of required research, and I fully encourage and respect the fact that question was asked, and I think it needs to be acknowledged.
Another question, thank you, had to do with genetic testing in Canada in terms of cost and access. Can somebody? Dr. Pfeiffer?
So there are about 5 different genetic tests that are available commercially right now in Canada for patients to use to assess their risk of familial familial associated prostate cancer and breast cancer too, because they basically look at the same thing. You're looking at the BRCA1 and 2 gene locus, also BRCA, as well as a couple other less common ones. But there are about 5 that are commercially available that I send patients to. It doesn't involve me, but as the provider, they send me the results, and it has and will continue to inform therapy moving forward, especially in younger people in terms of their risk of prostate cancer and their risk of transmitting genes to their progeny. And also it also can inform the treatment of patients with some of the very specific drugs that we have for BRCA1 and 2 patients later on in the disease paradigm.
What about cost?
Anywhere from $365 to $1,200, depending on how complex of an assay you want. It's basically you pay for what you get. You get a very, very narrow set of genes for the cheaper ones that are probably just are as much as you need, but the more significant ones provide a wider array. And there are some that are in the middle of the range, about $800, that are perfect. No need to do anything extra.
And how do people access these? Through their family doctor, or?
It would be through, they can do it through a family doctor. You can look online, to be honest. You can just Google genetic tests, prostate cancer in Canada, and you'll get, it's very commercially available right now. They send you a kit similar to like some of the ancestry.coms where, what's the common one that people use, where they send you a swab that you just send in from your mouth and so on, and you do your, there are a couple of different ones, but they're very, very commonly available.
23andMe.
23andMe, that's it. Thank you.
So Dr. Fife, I think this question is for you regarding the NED app. And it's around data privacy and confidentiality, and how would you address those?
Sure. I actually typed a note to this person in the question and answer. I'm happy to address it globally. Because the reason why it has taken such a long time to develop an application for prostate cancer patients that is as robust as NED is that we went through 5 years of privacy work working with eHealth Ontario and the Ministry of Health. We're actually the only application with direct access to the Ontario Laboratory Information System. Everything is HIPAA compliant and as adhered to the most strictest data standards, similar to typing in your name and password for your banking information. So we are, we're a vault basically, and we're pioneering in that way, and we're excited to be in that position.
There's a question in the chat, and it says, I noticed that Black origin are mostly high risk on various diseases like high blood pressure, prostate cancer, colon cancer, diabetes, asthma, stroke, kidney, and heart. All of these conditions disproportionately affect the Black community than other communities. Why? Do you think they're due to stressors, personal image, diets, particularly to the Black community, rather than DNA? I don't know who's going to take that one. Dr. Roberts?
I want to say it's a combination of all of those things. In fact, I was trying to remember offhand, but doing some review that there's a particular syndrome related to the stressing factors in our Black population with regards to the hypertension and the diabetes, etc. Of course, if you go all the way back, there's definitely a lot of evidence with regards to the transportation of the Blacks from across the Middle Passage, and those that survived and the ship journey, and what it caused on us over the years, and so it's there. A lot of it has to do with culture. When someone says, "What does culture have to do with it?" And particularly, for example, I was listening to very closely to Andrew's response with regards to the diet. And it is just the way we eat, as Dr. Twait showed earlier on. This is just how we eat, and particularly in North America, we have a very high fat diet, and it shows. It shows in our lifestyle disorders now. I mean, a little country like the Bahamas, we are ranking in one of the world's top 10 with regards to obesity and hypertension. And so when you look at culturally how it has affected us and the way we live and the way we eat, it's really multifactorial, and that's the best way to put it. And when you now begin to appreciate this whole field of epigenetics with regards to how we are currently and how it impacts our genes, and it actually changes our genetic constitution, that's mind-boggling to think. The stresses that we have placed on ourselves and how it will propagate in the generations to come.
There seems to be some question in the chat based on what I see there around when screening should start and stop. Could we just re-clarify?
Well, I think like we do in all these things, you have to really look at when you're going to get the best value or the most value for your screening. And we recognize that we then look at our risk group. We know that prostate cancer is a cancer of men as they age. And we also know that prostate cancer, because of its slow growth, that after a certain age, there's no value in screening because it's unlikely if you develop it that it will affect you. And when you look at the true meaning of screening, in that we look at a population at risk and we go out to them and we want to reduce mortality, that screening as a policy directive is very expensive. Okay, and you can't manage healthcare today without looking at the expense, how much it costs, and to realize that we live in a society today whereby health is just one of the many needs that we have, and we can't be in a position where health alone occupies all of our budget. We have education, we have housing, transportation. There's so many things that are important for us to live. And so when we look at screening policies as a population-based approach to healthcare delivery, we must be very cognizant about the returns on our investment. And so we have to listen to the authorities, the public health authorities, that tell us that this is when we should do or not. And what we can do as specialists is to modify those policies as we have done with the recommendations for prostate cancer screening when it came out, and say this is what we shouldn't do. And I think that the cries that came out from the NGOs and from the various urological associations impacted those decisions that subsequently were made. And so when I say in my population, and I say as young, we should start at 40, and we should end at 70. But bear in mind that you can have some good, healthy-looking men at 75 that that should be continued in the screen. So I can't emphasize that screening is not something that we take by itself. It's a population-based approach, and we all need to be included in those limits, and we need to take it seriously and see how we get the most return for our investment.
So we're just going to do 2 more questions because it's getting late. We've run over our time. There was a question about what types of treatments what are the various types of prostate treatment options in Antigua and Barbuda and the Eastern Caribbean?
I guess that's directed to me, Ken. No, we do have all the necessary options in the Eastern Caribbean. I could vouch for. We do the active surveillance. So we do have external beam available by the pavilion, which is based out of the Bahamas, and who have set up in the Eastern Caribbean itself, where they are available amongst all of the islands in the Caribbean itself. We try to have what we say a link between all the different islands who are available We do brachytherapy treatment available. We don't have robotic in the Eastern Caribbean. I've been trying to set up a satellite center through the University of Miami in Antigua to start doing some robotic surgery, but we can do the open surgery, and we do the open surgery very effectively. So all the necessary treatment options are available. Again, Dr. Roberts had shown the prices for some of the newer medications to treat the hormonal resistant prostate cancer. And the prices are very expensive. Through one or two, maybe three of the companies based out of Trinidad, we've been able to get some Zytiga. The Pavilion now is getting it at a cheaper price into Antigua. We're paying like for 30 pills, maybe about 260, 300 EC dollars, which is 100 US for some of the Zytiga that's available. But the other medication, apalutamide and all that stuff, are still very expensive and hard to get. But we do have a very good, comprehensive ability to treat prostate cancer with all the necessary options in the Eastern Caribbean.
Great, thank you. Anthony, there's one more.
I think, yeah, there's one that says what treatment, diet, etc. can improve the strength of a harder penis for insertion for sex in a prostate cancer survivor age 80 years old.
It's a tough one.
I want to take that one.
That's a general question.
Andrew, maybe we'll do a tag team on this. But
yeah, I was about to say the same thing, Andrew. You first, and we'll talk.
I'm not sure that there's any evidence in the literature that there's necessarily nutritional changes that you can make to have a more responsive penis after treatment. That said, though, it's very much related to what Andrew said, is that having problems with erectile functioning, not related to prostate cancer, can be an indication of cardiovascular problems. And so there is something to be said for that heart-healthy diet as being an important influence on erectile functioning. The healthier you are going in, the healthier you are coming out.
Agree fully. I usually tell my patients, and I do see a significant amount of octogenarians looking for a very normal, intimate life and so on. And I always say the heart, the penis is a window into the heart, and what's going on in the penis can often show us that there's something going on in the heart as well. The caliber of vessels supplying blood to the most important parts of the penis that are responsible for erection, the same caliber vessels as supplying the myocardium with blood that if plugged, give you a heart attack. So when I see patients who have that, I often have a dialogue with their GP or their cardiologist to have them assessed properly for any cardiac disease. And if they pass that and there's no cardiac disease, then we need to talk about expectations, which of course Andrew had mentioned, and so on. But there are various assisted technologies and medications that can help that are used with success, both invasive and non-invasive. And it's worthwhile to have a very important conversation with your provider. It's all I have to say is that communication is key. You can't be embarrassed. You got to talk to your providers of what you want in life to make you happy, and your provider should be able to help you. If they can't, refer you to somebody who can.
Absolutely. And just related to that quickly is the idea is that people that have a knowledge in sexual health do know their medications and their pro-erectile treatments very well. And the idea is to start off with the most or least invasive approach and move forward. Having realistic expectations of how PDE5 inhibitors like Viagra, Levetiracial, Stax, and the ones is, it's not where you're going to pop the pill and then slip into the back seat during a movie theater, a show as they show in commercials. That said, being really truly taking the time to with the sexual health specialist to learn how to take those medications can be helpful. The other thing to recognize is that unless we get to the much more invasive methods, these things are, they can be done and tried and then stopped. So it's nothing permanent that you're, in many cases, changing, unless, of course, you go to surgical implications.
I just want to add a little note here, particularly for Black men, and that's where the culture comes in. And we have a last resort. I would normally say to them, if you can't raise the dead, you can prop them up. And they really need to be able to accept that sometimes the only thing left is to have an implant. And for various reasons, and I think it's all cultural, that Black men have a major impasse when it comes to considering anything to do with some surgical treatment on their penis. And we really have to overcome that barrier for them who are, where their whole life has been turned upside down, to really be able to get the consultation to consider that a penile implant at the end of the day can give them a whole new life.
And Robin, just
Sorry.
Yeah, I couldn't agree more. And also, just as I said, even at the level of taking a pill, right? The idea that that you shouldn't be dependent on a pill, or you shouldn't need a pill. Remember, you underwent a procedure to cure you of a cancer, and under that procedure, the damage was occurred. It's not about willpower. It's not about manpower. It's not about skill. It's about actual practical tissue damage that that in some cases will result in erectile functioning that's not satisfactory for you, and the use of these medications all the way through to penile implants are options.
Thank you.
Just one more question before you run, Ken. Just finally, since we're in an era of talking about telemedicine online and all that, there was a question regarding data privacy, especially in small geographic areas. Could someone just touch on that briefly before we wrap up?
That would be Dr. Pfeiffer.
Yeah, no problem. I know that I can speak from our project and that of all the great privacy work that we've done. The advantage of having a big team and having worked with the government and so on is that we have a very fantastic data privacy platform. We've partnered with, I'll give you an example, with OneID, which is a data. It's the same. For instance, if anybody who's paid their taxes online in Canada has the option of logging into their bank to authenticate themselves, and then you're sent over back to the government website to pay your taxes there. So we use the login for your banking, which is very private and of the strictest privacy standards to actually log in to pay your taxes. Well, we use that for NED, and we're using similar technology for NED, such that it doesn't really matter where you're from, or where if you're in Jamaica, or if you're in Miami, or if you're in Toronto, the data is held privately in the cloud by some of the strictest and most incredible algorithms that we have that are available. So, anything's possible in life. People have been hacked and this, that, but we, just like everybody, such as the banks and so on, are doing everything we can to prevent a data breach.
Thank you.
And storage of data, just as Andrew was talking about, is that there are security levels, because the financial industry has, as he just mentioned, developed this level of security. People are much more interested in finding out how much money you are and how they can get it than finding out about your PSA. And so the idea, they have to have very strong security mechanisms there. And then in terms of actual at the moment discussions, not unlike what we're having right now, and I will do personalized counseling, couples counseling online. COVID has done a great job of advancing this technology. Zoom, as you guys know, got in a lot of trouble and is now trying to set itself up. We have an Ontario telenetwork that was very protected, but also was like using a dinosaur. So all of this type of healthcare is going to continue beyond COVID.
Right.
Thank you.
So I really want to express my appreciation to the panelists for staying with us almost half an hour past the time. All presentations today have been excellent. I would ask if you can give us some feedback in an email as to what you found good about today, what, you know, where we can improve. Just give us some feedback on this type of thing, because we want to expand this more, especially to the Caribbean, if we can do something like this specific to the Caribbean. I really want to thank you very much. And to all of the attendees who are still on with us, I noticed that people are dropping off, but they're still on. We really want to thank you. We're going to be sending you a survey in the mail so that you can give us your opinion, what worked, what didn't work, and any suggestions for us. We've got a lot of exciting things planned for the year, and so we want to actually share that with you and get your feedback on this. So I really want to thank everyone for joining us. It's been a really amazing day. I couldn't believe that the time, it was really 2 o'clock already, and we started at 9. But the day has gone so well that I think there's a lot of information that came out of it. Now, on the videos, we're going to be posting them on our website so people can go back and look at the speakers and get an idea of what was said. And we really love to get feedback from you as well. Our email address is info@thewalnutfoundation.com. Please let us know what you think. Thank you. Anthony, did you have anything to add?
Yeah, just want to add my thanks to everyone who helped to make this conference a success. And I know we didn't get to some of the questions, but you can email us and we'll try to get an answer for you. Again, info@thewalnutfoundation.com. And thank you all for your participation and for your ongoing support.
This has been truly an international panelist, and we really do appreciate it. It has been excellent for us. Thank you.
Thank you.
Thank you.
Thank you.